Actually, the title comprises a word which is the dilemma. And the dilemma is ICD in primary prevention. And I will focus my talk mainly on this problem. These are my conflict of interest. And I would like to start citing with a citation of a very interesting paper that has been published in Circulation recently. And these two very famous authors claim that risk stratification, and the paper was on sudden death, risk stratification is in many ways medicine's attempt to predict the future. And in fact, that's how it is. And what happens is, at least for cardiologists like us that face patients every day, you have, for instance, a 35-year-old male patient with HCM. He has a 25 millimeter septal thickness, no obstruction, and the question is often, should I implant an ICD? And when you face your patient, that's the question that rises in your mind. Is this the right question? I believe not. Because in fact, the question should be, what is this risk of AF, which is the most frequent complication? Congestive heart failure, and sudden death in 1, 5, or 10 years. And this is the question that should be a more complete one. And the wonder, and the data that we have, I don't know if they are sufficient at this point to let us answer this question. Prognosis has always been and is always be the most difficult part of our practice. Now, if it's true that doing the risk stratification is trying to predict the future, you have to know that there is a rule that every palm reader, I don't know if you ever went to a palm reader, but every palm reader has. And the rule number 1 says that if you would like to increase accuracy in prediction, make sure you are incredibly vague. And that's what I would somehow suggest to cardiologists and to people that see cardiomyopathy patients. However, let's go now to the facts that regard hypertrophic cardiomyopathy and sudden unexpected death. Sudden unexpected death is a catastrophe. It's a catastrophe for the patient, of course, for the family, but also for the doctor. It's a rare random event that may occur at any time in life, and it is usually, but not always, due to VF, because sometimes, of course, it's due to other causes. And these causes, if there is no autopsy, they are not ascertained. However, in most patients, and these data come from the interrogation of ICD, and we have already more than 10 years of experience on that VF may be preceded by sustained VT, sometimes by sinus tachycardia or atrial fibrillation. However, just to show you that it's a random event, I'll just cite one of the examples that Barry has published some years ago. Here you have the brother of this man that had died suddenly at the age of 35 years, and at 36 years, this individual had an ICD implanted. After 4 years, the generators were replaced. And at 41, he had the first appropriate shock. But he had to wait an additional 9 years before having a second appropriate shock. So it's very rare. It occurs randomly. And apparently, we don't understand the reason of it, at least in this case. Now, Barry published another paper in a journal that sometimes we forget to read, which is Heart Rhythm. And he published the data of 39 patients that survived a cardiac arrest. And as you can see on the top of this figure, there are the ones that had recurrences or had other problems. While you see here, there is the half of them that never had any other event related to the cardiac arrest. So they were free of cardiac arrest and free of death. So as you see, sudden death is really random, and this is another demonstration of it. Now, when you base your observation and your risk evaluation, you have to evaluate which are the causes of death in patients with hypertrophic cardiomyopathy. And I'll show this slide that comes from a paper where the population seen in the 80s and 90s from Minneapolis, Florence, and Genoa were put together, and we had a mean follow-up of 8 years, and the mean mortality, HCM-related mortality, was 1.4%. And as you can see, the lowest rate happened between 35 and 55. Then it went up for sudden death is in the red, and it was just slightly higher in the diagnosis made at the age between 5 and 15. But the question is, now, if we rely on this data, are these rates still valid in 2012, managed patients? Because now we see different kind of patients, and we are managing them probably differently. You have to remember that these patients were the first cohorts that we were following in our early times. Now, based on that, however, we have an attempt of recertifying our patients. And basically, what we can say is that these are the hard data that are available. The annual risk of sudden death is accepted as being, in general, less than 1% per year. And the range probably is between 0 and 7%. And 7% was the rate of recurrence of sudden death, of cardiac arrest, both in the population that we studied with Barry Meron in 19 and published in 1989, and the group of London, Per Elliott, published a few years later. The average probably is between 0.3, 0.9% on the average. So, at this point, with this data, we can build up a kind of pyramid which represents the risk stratification, and you can see that the risk can be as low as 0 and as high as 7%. And in the guidelines that have been published so far, of course, this is the risk cohort, the high-risk cohort, which has class 1 indication for ICD. However, let's go back to the paper that Barry Meron published a couple of years ago. And going back to that, as you can see, he analyzed out of about 1,000 patients, only 39 experienced either a cardiac arrest and they were resuscitated, or they experienced appropriate ICD shock, which is equalized to sudden death, aborted sudden death. And as you can see, I showed you before that 7 died for other reasons. One, you can see that had an ICD, and he was a young boy of 3 years, and then he experienced sudden death notwithstanding the ICD. And the other 32 that survived, half of them never experienced any other problem. So again, are we seeing really the same population that we collected some years ago? Probably we're seeing not the worst, but we're seeing the average population, and their outcome is a little bit better than we saw a couple of decades ago. In fact, the annual HCM-related mortality reported in this paper is 1.4% in the cardiac survivors, so much lower than the 7% that we found many years before. And actually, almost 90% of these patients that survived the cardiac arrest were free of HCM-related death. But I want to point out another paper where actually these are the so-called end-stage patients with hypertrophic cardiomyopathy. So these are patients that have experienced disease progression. They have gone into somehow heart failure, severe heart failure symptoms, and probably while waiting for transplant, they were either having heart failure death, but above all, they died suddenly. So this is the high-risk cohort, and in fact, the mortality in this cohort was 10%. So 10% a year. So in fact, probably the greatest high-risk group of patients is the one that really show disease progression and they show heart failure symptoms, class 3, 4. So I believe that we might think that our risk stratification pyramid probably should be modified and have at the top the heart failure patients instead of the survivors of the cardiac arrest. But the big dilemma, however, for the practicing clinician and cardiologist is not these high-level risk patients, but is the ICD in primary prevention at the base of the pyramid. So you have your patient, you assess the risk factors as everybody knows. You may either have or not, one or two, and then you have to decide either or how to propose the ICD to prevent sudden death. Well, let's go to some of the data that have been published some year ago and were considered at the base of the ICD guidelines for hypertrophic cardiomyopathy, both in 2003 and 2011. As you can see, the 5 risk factors, have a kind of a number of positive predictive value and negative predictive value. And as you can see, the numbers are rather low. And the level of evidence, based on the fact that this is not evidence-based medicine, is C. So I believe that, these data have really not such a big impact, in predicting, what will happen into our patients. In fact, and this is a slide that Per Elliott gave me some time ago, he has analyzed the ROC curve using the algorithm based on the guidelines that were published and valid, and published in 2003. And as you can see, the ROC curve shows a rather low value at 5 years, 0.64, so demonstrating that we are not really very good in predicting if we use these risk factors. In fact, they actually reanalyzed the predicted value recently, and they showed this slide at the recent Munich European Society of Cardiology Congress, and they reanalyzed a total of more than 1,600 patients that were seen at their center in London. And as you can see, the predictive value at 10 years increases with the number of risk factors, of the same risk factors that I showed you before, but however, it was still rather low. So the positive predictive value remains low even in the presence of multiple risk factors, and the aggregation of risk factors in a particular patient is associated with increased risk of sudden cardiac death. And this is basically what we should use at this point. And as I said, we're not very clever anyway if we just use that. The other point is, however, does this algorithm fits for all patients? And of course, it might fit for these two kinds of patients, massive hypertrophy, mild hypertrophy with some kind of obstruction and mitral regurgitation. What about this? And we know how variable is the phenotype and the disease and how it changes and is dynamic during life. So I think that we cannot assess risk just with using these risk factors. Another example, you have here hypertrophy. This is a 17-year-old girl. This is a 16-year-old boy. They look the same, apparently. However, if you do a PET study, which is a study using dipyridamole and trying to obtain maximal flow after infusion of dipyridamole to see whether the intramural coronary artery system works and increases the flow after dipyridamole, you have a clear difference between this case and the other case. This is the level of increase is absolutely very small, 1.6, and base is 1. And in the other case, almost normal, 3.9. And the difference here is that this girl has a heavy chain, beta-myosin heavy chain mutation, and in the other case, we haven't found the mutation, so we don't know exactly what's the cause of the hypertrophy. However, they look the same, but they are clearly absolutely different. Another point of criticism is the fact that when we see the patient, and this is our proposal, above all, we've been working on this with Jacopo for a long time, and we reported in this paper, which has been recently published, that after all, when you see a patient, you have to try to stage the disease. And of course, we called stage 1 the gene carriers, and we called them non-hypertrophic. And then you have the classic phenotype with ejection fraction above 65% in stage 2, and usually this patient have a rather stable course. And then you have the adverse remodeling, which we call stage 3, and probably they account for about 15% of the patient population, and where the ejection fraction apparently is normal, but has already lower than expected in hypertrophic cardiomyopathy patients. And a small subgroup of this stage 3 then will go into over-dysfunction, what has been called before end stage, and it's a group of cohort of about 5–10%, where in fact you find an ejection fraction below 50%, which is definitely very low for hypertrophic cardiomyopathy patients. So when you think about risk, you have to try to adjust your risk depending also on the stage that the patient is in. And the stage can be also well detected by not only by ejection fraction, but probably by the correspondence of left ventricular of the presence of late gadolinium enhancement in the left ventricle using MRI. And as you can see, if you have a good ejection fraction, so stage 2, usually the level, the volume, the mass of the late gadolinium enhancement is rather low. It increases and has a parallel with the stage and the lowering of the ejection fraction. So in fact, I believe that late gadolinium enhancement extension and value is just a marker of disease progression, and it helps you to stage your patient, basically. Now, what about obstruction? Obstruction is not considered in the algorithm. It's being considered in the last guidelines that were published in 2011 by the American group. And as you can see, about 10 years ago, we showed that if you have obstruction, you have clearly a mild increase in sudden death. Actually, you have a twofold increase. And the London group from Perry Elliott also showed that obstruction increases the risk of sudden death. And actually, they were able to show that there was a stepwise increase depending on the value of the obstruction. And their increase in sudden death rate was definitely greater than ours. However, what happens if you do a myectomy? Well, when we reanalyze the data for sudden death, putting together the data from Minneapolis and Florence versus the Mayo Clinic patients that had been operated, myectomy almost abolished the sudden death risk. And this is usually not taken in account in the restratification method. Lastly, there is a paper published by Barry very recently, again in Heart Rhythm, where he had a cardiac arrest in this patient who didn't show any risk factor, but at the same time, he had 2 mutations. So I think that we need also to start a reappraisal of complex gene mutation effect on the sudden death risk. This has been emphasized over 15 years ago, and then it has almost forgotten and said that it was useless. I think that we have to reconsider that. Because genetic basis, the genetic cause of the disease, clearly not only let us understand better what kind of disease we are facing, but probably there are differences in the single gene mutations that then may really carry a different risk for sudden death. So I believe that to improve the risk stratification, which so far is far from being perfect, we need to reassess risk of sudden death in large patient cohorts, including pathogenic genetic mutation. And so far, we have a fair number of patients that we could put together and reanalyze under that. It might be that, as we showed in one paper, more than one pathogenic genetic mutation carry a higher risk, or some specific mutations might be reanalyzed regarding risk of sudden death. Also, disease staging, as I showed you before, left ventricular, left atrial remodeling, ejection fraction, mass of late gadolinium volume, presence of proBNP and VO2 max value, and also how we manage our patients. If you remove the obstruction or if you remove atrial fibrillation, clearly you probably improve the survival, but also you probably reduce the risk of sudden death. And we should also work on additional risk factor validation, like, for instance, ECG abnormalities. I haven't got the time to discuss about it, but there are a few papers that show that some kind of ECG patterns might have a value in the risk stratification. Now, let me just briefly talk about the fact that sudden death prevention actually relies on ICD. And of course, ICD is a wonderful device that may save your life, but you have to pay a price. And I believe that Dr. Bongiorni will talk about it later. However, the price you pay regards inappropriate discharges that are mostly related to atrial fibrillation or sinus tachycardia. And this is important because, of course, you can prevent them either by drug therapy or using appropriate algorithm for the ICD. But above all, you might have infection and sepsis, which are reported in up to 5% of the patients, hemorrhage, thrombosis, but above all, lead failure or fracture. However, in general, quality of life might be reduced, and this is often occurring in young people that, that may show depression, and you might have also driving license problems. One of the papers that reported more clearly the device complications was the one by the group of London again, who analyzed a group of fairly large number of patients which had the ICD implanted mostly for primary prevention. And their conclusion here was that HCM patients with an ICD have a significant cardiovascular mortality and are exposed to frequent inappropriate shocks and implant complications. This data suggests that new strategies are required to improve patient selection and to prevent disease progression in those that receive a device. So implanting a device and talking about it with the patient and probably with the family is a deal that the cardiologist and possibly the electrophysiologist should always make, both with the patient and the family, after careful explanation of risk, benefit, as well as potential complication, reduced quality of life, and lifestyle change. And let me just tell you about something that at the moment might look like the Holy Grail. It has already been presented yesterday by Jacopo, but this preliminary data from our group and the group of Professor Mugelli and Professor Cerbai in Florence have showed that this is the membrane potential of the cardiomyocyte of hypertrophic cardiomyopathy patients that can be normalized in using ranolazine, and above all, the after potential, can be reduced, using this drug. I don't know if this will show beneficial for all patients. I don't know if this will be beneficial even in a single patient. We have started now a clinical trial, but this is a promising drug that might be either this one or maybe future drugs might somehow help us to solve the problem. And I thank you very much for your attention.
I have just one comment, and I'd like to know your opinion. You showed Perry Elliott's slide on the multiple risk factors, and I see that patients had a positive predictive value of dying suddenly of 65% at 1 year, which dropped to 25%, say, at 10 years, which means that a lot of patients died between year 1 and year 10. So these factors are not sufficient. We don't know what to do with patients with 1 or 2 risk factors, but with many risk factors, well, they're not that bad, I believe. What do you see?
Maybe I was not clear. I think that, of course, each of us uses these risk factors, and I don't want to mean that the risk factors that are currently available are not useful. I would say that they are really mildly useful. So, as I said, the risk factor stratification is far from being perfect. I don't know if it will ever be perfect, but however, the attempt to see whether using either these 5 or some is so far not, doesn't make us happy, doesn't really make us predict our patients. We can see again the paper that was published by the London group reporting the complications and the appropriate shock, and the appropriate shock actually are lower than inappropriate shock and complication. So when you do a preventive strategy, even for a phenomenon which is so catastrophic as the sudden death, well, I think that you have always to consider how you impact on the patient, how much burden you give to the patient. And with Maria Grazia Bongiorni, we had to remove some of the ICD in our patients that definitely didn't want to accept any other complication or inappropriate discharge. So I don't want to mean that this should not be used, but this is not perfect. And I think that we have to consider that very carefully, when and how to implant.
I have a question. So how much may be you influenced by knowing the type of mutation that the patient has?
I think that we are somehow influenced. For instance, we have had anyway, there are published, about 10 years ago, they published a list of so-called malignant mutations. And I believe that we can discuss this with the patient, that there are some reports. But I mean, that's what I wanted to mean. We should collect data on the same mutation, probably coming from Barry Maron's group, from a London group, put them together and see whether these so-called malignant mutations are still valid as malignant mutation. Because, we had a positive report from that paper, then we found 10 families who had absolutely no sudden death, and we decided that this was not true. But, at this point, we don't know. I believe that more than a single mutation, we are puzzled more by complex mutations which we've already shown to have an impact on the subsequent course and disease progression, mostly for heart failure, not for sudden death.
We have another question. Yeah. There. Signori lì, guarda, quello in grigio con la mano alzata a sinistra sua.
I want to ask about the fact that ICD interfere with MRI diagnostics for future evolving of the disease. Is this a factor also to consider? Or not in the evaluation of
I don't think so. I don't think this is, of course, a problem. I mean, after all, you cannot have late gadolinium enhancement, but I mean, people survive anyway, and you can deal and manage your patient even without MRI. After all, if you need to look for some other additional problems, like, for instance, left ventricular or left atrial thrombus or the formation of aneurysm, you can still use CAT scan. So, I mean, that's not really such a big problem, while we wait for an ICD which is compatible with MRI, like they did with the pacemaker already.